Are you ready to elevate your expertise in the pediatric cardiology field? Welcome to the Pediatric Cardiology Fellowship, a premier one-year online program designed to equip you with advanced knowledge in the pediatric cardiology field. Our aim is to provide you with high-quality educational materials and up-to-date pediatric cardiology scientific knowledge delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is high quality, up-to-date, evidence-based, and well-structured. Why travel for training when you can learn from top pediatric cardiology experts online? Our program brings world-class instruction directly to you, no matter where you're located, through case-based discussions, Q&A sessions, virtual workshops, and personalized feedback. You'll receive high-quality education
that augment and complement your personal training,
all from the comfort of your home or workplace. Our pediatric cardiology program offers a comprehensive fellowship structured into 3 modules, 16 weeks each, with a total of 96 credit hours and in-depth training over 1-year period. Balancing work, life, and professional development can be challenging. Our Pediatric Cardiology Fellowship is designed with your busy schedule in mind. With self-paced learning modules and live virtual sessions, you can advance your skills without disrupting your clinical duties. This program allows you to learn and gain experience at your own pace. From mastering congenital and acquired heart diseases to specialized training in ECG, echocardiography, cardiac imaging, including MRI, diagnostic heart cath, electrophysiology and arrhythmia management, mechanical circulatory support, and cardiac critical care, you will develop the essential skills to manage children with various kinds of heart disease at any circumstances and healthcare setting. Upon completion, you'll earn an internationally recognized AACME accredited graduation certificate, helping you enhance your credentials, advance your career, and improve your patient outcomes. Join a growing community of pediatric cardiology professionals who have transformed their careers with this fellowship. Don't miss this opportunity. Take the first step towards mastering the pediatric cardiology specialty and transforming the way you deliver care to your sick children. Visit our program landing page and register to reserve your spot. Limited seats available. Don't miss your chance and register today.
Hello, everyone, and welcome to our Pediatric Cardiology Fellowship Program webinar. Today, we have very special webinar and very special guest speakers and moderators and panelists. And we focus on pediatric arrhythmia from ECG to emergencies. Some of these arrhythmias are life-threatening, and early recognition, identification, and proper, precise management would impact our patient life. So our first speaker would be Dr. Ghadir Nejouia. She is from Palestine, and our second speaker is Dr. Sanatani Shaw, who is going to give us a very nice demonstration on Wolff Parkinsonian White. Our great moderators today are Dr. Najib Dadah from Canada and Dr. Omar Al-Junaid from Saudi Arabia. Here is our humble agenda today. So we'll have 10-minute case-based discussion by Dr. Ghadir, then WBW by Dr. Sanatani. Then we will have, by the end of the session, a 10-minute QA and discussion. So if you have any question, inquiries, please feel free to put it in the QA box. Again, our first speaker, who is going to give us very nice case-based discussion, is Dr. Ghadir. She is a pediatrician in Palestine Ministry of Health. And our second speaker is Dr. Sanatani Shaw, who is going to talk about the WPW. Dr. Omar Junaid is a consultant pediatric cardiologist at King Salman Heart Center, Riyadh. Dr. Najib Dadah is a pediatric cardiologist and a professor of pediatric cardiology at University of Montreal. Some take-home messages here. All attendees should receive certificate of attendance by next week. If you have any question, put it in the QA box. And if you want not only to hear the lecture, but also to see the transcription over your screen by your own language, you can do that by activating or enabling the show caption option. Again, we are not here to teach you the fact, but to train your mind to think, because we either think or think. So with that, I'm going to let Dr. Ghadir to give the first presentation. It would be very nice case-based discussion that you are going to learn from her today.
Hello, this is Dr. Ghadir, and I'm going to present a case from the Turkish Society of Cardiology for an 11-year-old boy with exertional collapse and drug refractory tachycardia. The story started for that 11-year-old boy who previously was healthy with no medical history when he was riding his bicycle and he went through a sudden cardiac arrest. He was successfully resuscitated by bystanders and EMS field providers. After that, he was admitted to the pediatric ICU for post-cardiac arrest care, where he experienced 4 distinct episodes of polymorphic ventricular tachycardia over a 2-day period, each requiring electrical defibrillation. Post-resuscitation baseline ECG demonstrated mild sinus bradycardia. The corrected QT interval was borderline, calculated at 463 milliseconds. There was no electrolyte imbalance, and urgent echocardiography reveals structurally and functionally normal cardiac anatomy with a preserved ejection fraction. Empirical propranolol and intravenous magnesium was started. Then the patient was discharged after 42 hospital days, during which his neurological status gradually improved. 1 week post-discharge, he went for follow-up at another clinic. His resting ECG showed a heart rate 56 beats per minute, PR interval 156 millisecond, QRS duration 100 millisecond, and stable normal corrected QT interval at 442 millisecond. The family history was negative for sudden cardiac death or unexplained syncope. Echocardiography shows normal ejection fraction, 62% with mild non-specific left ventricular posterior wall trabeculation. Exercise stress testing was deferred due to residual post-arrest neurological limits. Family declined adrenaline challenge test. The clinical history was highly suspicious of catecholaminergic polymorphic ventricular tachycardia, which led to urgent genetic sequencing, and accordingly homozygous ryanodine mutation was detected. Hence, a definitive diagnosis of CPVT was confirmed. So, propranolol was titrated aggressively to a therapeutic target of 4 mg per kg per day, and flecainide started initially at 50 mg per square meter per day in 2 divided doses, then reduced to 30 mg per square meter per day as a QRS widened to 150 milliseconds. The patient remained stable for 3 months with optimized physical therapy. Then, on a routine outpatient visit, regular sustained wide QRS tachycardia was suddenly captured. This instantly raised alarm for recurrent drug refractory CPVT, triggered ventricular arrhythmia, versus SVT with aberrancy. So, adenosine challenge test was done, and the rhythm was suggestive of supraventricular tachycardia, utilizing the baseline apparent conduction pathway. This is the ECG during the tachycardia. Then 24-hour Holter monitor demonstrated a persistently rigid and varying heart rate between 120 and 130 beats per minute across day and night. Normal autonomic beat-to-beat variability was completely absent, producing a flat line, almost flat line trend. The rhythm was suggestive of ectopic atrial tachycardia with baseline apparent conduction mimicking wide complex VT, while VT couldn't be definitely excluded. So propranolol was raised to 5 mg per kg per day. Sotalol 90 mg per square meter was added in addition to flecainide. And despite these three medications, the tachycardia persisted. During antiarrhythmic treatment, flecainide therapy caused unsafe slowing and shows a pro-arrhythmic pattern. A QRS stretched to 150 milliseconds and corrected the QT interval prolonged to 500 milliseconds. So the decision was taken to temporarily discontinue flecainide under close monitoring in the hospital and to initiate selective blocker ivabradine at 0.1 mg per kg per dose twice daily to suppress the ectopic atrial automaticity. And guess what? Clean termination of the drug-refractory ectopic atrial tachycardia occurred exactly 6 hours after the first dose, restoring stable sinus rhythm. Electrophysiological study was deferred and the patient was discharged on propranolol and ivabradine and scheduled for a protective left cardiac sympathectomy. This is the ECG after initiation of ivabradine. Now coming to the questions. Number one, based on an exertional sudden cardiac arrest while cycling and subsequent recurrent polymorphic ventricular tachycardia, what the primary cellular mechanism driving this arrhythmia is A. Delayed after depolarization triggered by spontaneous diastolic calcium leak from an unstable sarcoplasmic reticulum store. B. Early after depolarization secondary to an intrinsic genetic block of the delayed rectifier potassium current. C. Macro re-entry around an ischemic ventricular scar tissue zone localized to the left ventricular apex. Or D. Abnormal automaticity arising from downregulated fast voltage gated sodium channels. Exactly, the answer is A. Stress or exercise stimulate hyperactive ryanodine channel to leak calcium in during diastole. Intracellular calcium overload forces the sodium calcium exchanger to run in forward mode, generating a transit inward current. This depolarizes the cell membrane, creating delayed after depolarization that initiate lethal polymorphic ventricular tachycardia and sudden cardiac arrest. Question 2. How should the early finding of a borderline rested corrected QT interval 463 milliseconds and mild bradycardia guide clinical reasoning in the pediatric post-resuscitation patient? It definitely confirms congenital lung syndrome type 1 overriding any other clinical presentation. B. It highlights a critical diagnostic clue to CPVT, as these patients characteristically demonstrate a normal or only borderline corrected QT interval at rest along with sinus bradycardia relative to age. Or C. It points exclusively to a primary defect in the cardiac ryanodine receptor poor structure that directly block potassium efflux at baseline. Or D. It indicates a severe hyperkalemic state that requires urgent administration of calcium gluconate before beta blockers. And the answer is B. It highlights a critical diagnostic clue for CPVT, as these patients characteristically demonstrate a normal or only borderline corrected QT interval at rest along with sinus bradycardia relative to age. Question 3. Given a patient whose 24-hour Holter monitor demonstrates a rigid, persistently elevated heart rate yielding an almost straight line trend throughout the day without beat-to-beat variability, what does this specific pattern signify? A. Normal physiologic sinus tachycardia driven by anxiety or mild physical exertion. B. Orthodromic atrioventricular re-entrant tachycardia causing episodic paroxysm. C. An automatic or focal arrhythmia. such as ectopic atrial tachycardia, which has taken over as the primary pacemaker and operate independently of normal autonomic sinus variability, or D, type 1 atrioventricular nodal block with normal sinus pacing. And the answer is C, an automatic or focal arrhythmia such as ectopic atrial tachycardia, which has taken over as the primary pacemaker and operate independently of normal sinus variability. Patients with ryanodine mutation demonstrate a noted vulnerability to atrial arrhythmia, including focal automatic tachycardias. What is the precise molecular mechanism of action of ivabradine that allowed it to rapidly resolve this patient drug-resistant automatic ectopic atrial tachycardia, where other choices failed? A, open state channel blockade of voltage-gated L-type calcium channel. B, selective inhibition of the rapid component of the delayed rectifier potassium current. C, direct and selective blockade of the hyperpolarized activated cyclic nucleotide gated channels, inhibiting the funny pacemaker current. Or D, antagonism of the cardiac sodium channel exchanger or protein pump. The answer is C. Ivabradine block the hyperpolarization activated cyclic nucleotide gated channels, inhibiting the funny pacemaker current. And the conclusion and core takeaways: CPVT frequently present with unremarkable resting parameters, mild sinus bradycardia, a normal or borderline corrected QT interval should trigger high clinical index rather than diagnostic dismissal. And the ryanodine gene is expressed globally in both ventricular and atrial tissue, making CPVT patient highly susceptible to complex SVT and ectopic atrial tachycardia rhythm masquerades. So, when multi-channel blockade triggers adverse repolarization or conduction risk, selective blockers like ivabradine may offer clean targeted rhythm control. And of course, further multicenter prospective studies are required to better define ivabradine role in the management of supraventricular arrhythmias in CPVT patients. Thank you.
Great presentation. Thank you so much, Dr. Ghadir. Now, Dr. Najib is going to introduce our second speaker. And Dr. Najib is a professor of pediatric cardiology at Montreal University. Please go ahead, Dr. Najib.
Thank you very much, and thank you for the first presentation. This was really a good one, Dr. Ghadir. It is my pleasure and honor to present the second speaker, Professor Shubayan Sanatani, who is a professor and section head of heart rhythm services at BC Children's Heart Center in Vancouver, British Columbia. He is a dear friend and dear collaborator in research, leading multiple research works on arrhythmia in children. His topic is today on updates and management of Wolff Parkinson White.
Thank you.
Hello, my name is Dr. Shubayan Sanatani, and I'm a pediatric cardiologist and electrophysiologist based in Vancouver, Canada. I'm delighted to be speaking to you today on behalf of the World Institute of Critical Care and Emergency Medicine in their pediatric cardiology program. I'm speaking to you today about Wolff Parkinson White, and you'll notice there are no qualifiers in the title, as this will really be an overview with some of the historical context, and I hope to provide some insight as to why this is such an interesting arrhythmia condition. You'll see in the corner a cartoon of a wolf in sheep's clothing, which is often an analogy for conditions which may appear benign but can be dangerous. The condition is named for these authors, Wolff, Parkinson, and White, who published in 1930 a series of 11 patients. They noticed a combination of a bundle branch block pattern, abnormally short PR, and these were otherwise healthy individuals, fairly young. Even at this point, they described an interesting effect, the effect of vagal stimulation. More specifically, when the vagal tone was released, the PR paradoxically lengthened. So this means that as the heart rate increased, the PR actually got longer. So what they are describing, we now understand, is that the accessory pathway was not conducting at higher heart rates. These were not the first individuals to describe this pattern, and in fact they credited the work of the early 1900s, where there were many important electrophysiology insights, such as George Mines. In the late 1930s and early 1940s, more cases started to appear, and the term Wolff-Parkinson-White was coined 10 years after the paper. The first use of the term pre-excitation was in 1944. And this is a picture of the title page of this article. It's an impressive article, 167 pages, and 70 cases were reported. Pre-excitation indicates an additional excitatory spread in the ventricles of the heart coupled to auricular or atrial excitation. In that same year, the term delta wave was coined. It was acknowledged fairly early on that WPW was not the only form of pre-excitation, but the most common. The first report of an infant occurred in 1947, and here we have, again, short PR intervals and paroxysmal tachycardia in an 8-month-old. This baby also had presumed congenital heart disease, and you can see the delta waves on the ECG, similar to what had been described earlier. Now, Wolff-Parkinson-White and the discovery of the underlying substrate is really one of the most interesting historical stories in electrophysiology, and it gave us a tremendous understanding of arrhythmias and what we understand today. So the initial description of an atrioventricular connection was actually in Italy by Palladino in 1876, quite a bit before Kent. And Kent actually described fibers which they thought may be the original or maybe the actual AV node, and were later determined to actually be right lateral fibers. The AV node, of course, was described in 1906 by Tawara. The real unraveling of the accessory pathway in Wolff-Parkinson-White is nicely described by this case of a 13-year-old by Wood, Wolfert, and Geckler. And I'll just highlight one of the findings of this: 3 muscular connections at the right lateral border of the heart. This individual unfortunately died, underwent a detailed autopsy which included sectioning of the heart and the AV groove. And this was the first recognition that these accessory pathways were separate from the AV node, and likely the reason for the short PR interval and the tachycardia. Now we, of course, we understand the concept of pre-excitation, and here is a cartoon where you have activation of both the ventricle, both through the AV node and also through this accessory pathway. And so pre-excitation really is a form of fusion where the ventricle is depolarized by 2 differing wave fronts, and the degree of pre-excitation will depend on how much is going through the accessory pathway versus the AV node. And so this is a dynamic finding. So here is an ECG of a child with pre-excitation in sinus rhythm. And of course, one of the key findings of Wolff-Parkinson-White is that in sinus rhythm, there is an abnormality of the ECG. And here it is amplified, and you can see there is no isoelectric line from the end of the P to the onset of the QRS. And this has the shape of the Greek letter delta, and so a delta wave. Now, you'll notice that I've not been using the term syndrome because, in fact, Wolff-Parkinson-White syndrome denotes that there are episodes of tachycardia as well as pre-excitation, whereas a Wolff-Parkinson-White pattern, which is more common than actually having paroxysms of tachycardia, is referred to as a Wolff-Parkinson-White pattern. And of course, in the pediatric realm, we see quite a few patients who can have a Wolff-Parkinson-White pattern on their ECG, but also have palpitations without documented tachycardia. And so one shouldn't assume that there is an arrhythmia going on until it is documented, because palpitations really are quite common in our population. There are anatomical associations with pre-excitation, most commonly Ebstein's anomaly, which is a disruption of the tricuspid valve and a very abnormal right AV junction. The common factor in most of the conditions associated with pre-excitation are just that, is that the normal AV ring, the fibrous skeleton, is disrupted and there are accessory pathways. Ebstein, of course, has much higher incidence of multiple pathways because of the complexity of the valve. One of the associations with cardiomyopathy was led by Michael Golub, who works in Toronto in Canada and was instrumental in the discovery of this substrate, the PRK-AG2 form, which is actually a metabolic condition which is associated with pre-excitation. And so some of the familial cases are in fact due to familial forms of cardiomyopathy or metabolic conditions. Now, of course, Wolff-Parkinson-White can present with, as an incidental finding on an ECG, a screening ECG in an asymptomatic patients. We see this a lot with patients who are undergoing screening ECGs for consideration of stimulant medication, for example. However, in pediatric populations, it's most common to have symptomatic palpitations and be documented to have orthodromic SVT. This is generally well tolerated. The infants are often in tachycardia for many hours. They may present after 24 or 48 hours in tachycardia as a first presentation. And here is an ECG of a child with fairly typical narrow complex orthodromic tachycardia. Orthodromic, of course, because the antegrade limb is the AV node in the His-Purkinje system. On this resolution, it's not that easy to see, but there are subtle deflections in the ST segment. In particular, you can see them in lead 3, and this is consistent with a P wave in the ST segment. Now, when you look at this tracing, you don't actually know that the patient has pre-excitation, and in fact, there is a differential diagnosis to this tracing. This could, in fact, be an atrial tachycardia. Of course, if you know that the patient has Wolff-Parkinson-White and they present with this, then you will presume that this is going to be atrioventricular reciprocating tachycardia, or AVRT. Now, this is a reentrant tachycardia, and you can see the basis of reentry is two conduction pathways. They are not necessarily extra pathways. The same arrangement can exist within the AV node in the case of AV node reentrant tachycardia. There is block, unidirectional block in one limb and conduction down the other limb, and then retrograde conduction when the other limb has recovered. And so what this looks like, I'll show you in the next slide, but orthodromic tachycardia is the most common form, with the accessory pathway being the retrograde limb from ventricle to atrium, and conduction being through the His-Purkinje system, and thus the narrow QRS. It is, of course, possible to have rate-related aberrancy, which we're not going to go into more today. This is an ECG that captures the onset of tachycardia. You can see in the first several beats there is the typical appearance of sinus rhythm with a delta wave, and then this circled beat shows that suddenly the delta wave is gone. There is an isoelectric segment, and this is the initiation of the tachycardia. So antegrade conduction has been blocked in the pathway, leaving it able to conduct retrogradely, and thus we have the reentrant normal complex or narrow complex tachycardia. Now, a small percentage, probably 5 to 10% of patients can present with what's called antidromic tachycardia. And here you have a wide complex tachycardia with a right bundle branch pattern and a left axis deviation. One might be inclined to think of this as a ventricular tachycardia, which would not be, you would not be mistaken if that was on your differential. Less likely to be aberrant conduction with right bundle and left axis. And so in antidromic tachycardia, the accessory pathway is serving as the antegrade limb, and then the AV node may be the retrograde limb, or as shown in this other figure, there may be another accessory pathway, either a concealed accessory pathway or even a manifest accessory pathway. So antidromic tachycardia is uncommon, but it may be the presentation. And if one knows the patient to have Wolff-Parkinson-White and one sees a wide complex tachycardia, it would still be reasonable to give adenosine with the usual provisos of how we give adenosine safely. Now, a unique association with Wolff-Parkinson-White that makes it another factor which makes it very different from other forms of supraventricular tachycardia is the association of atrial fibrillation. Atrial fibrillation occurs in many adults as they age. However, it occurs in Wolff-Parkinson-White at a much higher prevalence. Ventricular fibrillation can result because the accessory pathway allows conduction both through the AV node and through the accessory pathway. And a rough estimate is if the accessory pathway can conduct 4 beats per second, that could be a high-risk pathway, or about 240 beats a minute. Now, this is a ECG that one can see, especially in adolescence, where we have an irregular tachycardia. The rate is quite irregular. It is wide. And one wouldn't necessarily think of this as pre-excited atrial fibrillation unless one is familiar with the appearance. Ventricular fibrillation is not usually this organized, and ventricular tachycardia is not typically this irregular. Could this be some other form of atrial tachycardia with variable AV conduction? It can be, but knowing the irregularly irregular pattern, one would definitely think of atrial fibrillation in a pre-excited patient. Now, this is potentially an emergency and should be handled quickly and cautiously. If the patient is hemodynamically compensated and is managing this, it is not necessary to sedate them right away and cardiovert them. Procainamide can be very effective, but it needs to be done in a center with some experience with this. Another Canadian who contributed to this story, Dr. George Klein, who is of course a very well-renowned electrophysiologist, when he was at Duke, he described a series of ventricular fibrillation in Wolff-Parkinson-White and did in fact find that the antegrade refractory period of the accessory pathway was shorter in those who presented with ventricular fibrillation. Now, the reason for the atrial fibrillation in Wolff-Parkinson-White are not entirely understood. It can in fact be the presenting arrhythmia, and it may be as common as 1 in 3 patients with Wolff-Parkinson-White, which is actually more common than in the elderly population. And there are some theories about this. Maybe it's a micro-reentry. Maybe the pathway has some automaticity. Perhaps it's secondary to sinus bradycardia, although we don't see a lot of adolescents who have sinus bradycardia without pre-excitation present with atrial fibrillation. Perhaps one of the most interesting concepts is that after ablating the accessory pathway, we do not tend to see recurrent atrial fibrillation, meaning that somehow the pathway was implicated. Now, people wonder, of course, whether patients have had unrecognized orthodromic or antidromic SVT that then degenerates into atrial fibrillation, and we certainly see this in the EP lab. However, this history is not always suggestive of a longer episode. So I think this still remains a bit of a mystery. Now, are we able to determine who is going to develop atrial fibrillation? Not to my knowledge, not at this point. However, we have looked at what some risk factors are, and as I mentioned, the ability to conduct rapidly, 4 per second, would be a fairly rapid pathway. In a pediatric study, they found an R to R interval of 220 milliseconds. So if the accessory pathway can conduct at 220 milliseconds, which is a rate closing in on 300 beats a minute, that's a high-risk pathway. Now, again, one of the challenges is that most of our studies are done with patients under some form of anesthetic, and isoproterenol can be used to accelerate the pathway. So we are still sorting out whether we are good at determining high-risk pathways or not. Now, on the bottom, there's a tracing that is quite interesting. You can see an alternating pattern. So there's a QRS which is upright and then one which is downgoing. The downgoing one has a clear isoelectric line. The P wave is on top of the end of the T wave due to the relatively rapid heart rate. And the upgoing one can look quite closely and one can see that there is a gradual onset to the QRS. There is a little bit of electrical activity and then not quite a textbook delta wave, but certainly some slurring of the QRS. So in fact, what is happening is every second beat is pre-excited. Now, sometimes ventricular bigeminy can look like this. However, we have here clearly a P and a P-QRS relationship that is one-to-one with consistent AV intervals. And so this is intermittent pre-excitation. Now, the reasons for this at a higher rate, here we have a ventricular rate of about 140 beats per minute. That may just speak to the refractory period of the accessory pathway. However, at low rates, one can also see intermittent pre-excitation. And the reasons for this, again, are not entirely clear. There are some theories about why the conduction is intermittent. Intermittent conduction through the accessory pathway has historically felt to be a low-risk pathway. However, a Wolff-Parkinson-White registry, which has led to several insights in recent years, also identified that several patients with intermittent pre-excitation can have high-risk pathways and life-threatening events. A word briefly about digoxin. Digoxin is one of my favorite medications to treat supraventricular tachycardia, particularly in infants, and brief history about its use in Wolff-Parkinson-White. The use was widespread in the early era. We have gone away from using DIG in Wolff-Parkinson-White, not necessarily based on abundant data. We do know that Wabane, which is an analog of digoxin, can accelerate the refractory periods, and that's the early work by Dr. Wellens. This is not in humans, but in a lab model of it. However, people have used digoxin, especially in newborns and infants, and there have not been many cases of adverse events. I think at this point, especially if one doesn't know about the Wolff-Parkinson-White, people may use digoxin to terminate SVT. We are probably due to have another talk about the acute management of supraventricular tachycardia, so I'm only going to touch on a few aspects of it today. The acute treatment, as all of us know, depends on the condition of the patient. If the patient is maintaining it's mentation and is not lethargic or unresponsive, then we have time. So if the patient is thinking, then you also have time to think. And so vagal maneuvers in infants that will usually be ice. In an older child, we can sometimes get them to cooperate with blowing on an obstructed straw or even on a syringe. I find in the age group from about 2 to 8, being inverted, so a handstand or being held upside down works very well. And I can combine that, being held upside down, with blowing on a straw. And so vagal maneuvers can certainly be effective, and that's one of the things I use for the families at home. Now, of course, adenosine is widely used, and adenosine can be given when a patient presents with a narrow complex tachycardia. We would not recommend adenosine for the irregular wide complex tachycardia. Now, adenosine could also safely be given in the antidromic tachycardia. So if you know that the patient has Wolff-Parkinson-White and is there with antidromic tachycardia, you can give adenosine. A qualifier, whenever you use adenosine, actually for any patient, you should be prepared in case there is an arrhythmia that you are not expecting. Adenosine can cause atrial fibrillation, not just in Wolff-Parkinson-White patients, but it can precipitate it in patients who are presenting an SVT. Now, of course, we will have a low threshold in a patient who is lethargic or otherwise seems unwell for cardioversion. As we mentioned in a previous talk I gave, the threshold for cardioversion really should be based on factors like mental status and not necessarily skin perfusion or blood pressure. Blood pressure is very hard to measure in an infant with a heart rate of 250. Now again, you will not necessarily know that the patient has Wolff-Parkinson-White when they present for the first time with a narrow complex tachycardia. So it's possible that they will receive a medication like verapamil, but once they are known to have pre-excitation, it is best to avoid those medications, as those also can accelerate conduction through the pathway. Now, here is a very nice tracing of something that we get called about a fair bit. This is a presenting narrow complex tachycardia. The adenosine is given, not right where it is written there. It's been given a few seconds before through a large IV with a good push right away. And there we see the effect. And there is a transient interruption of the arrhythmia with 2 sinus beats and then a pause. The pause is actually because there is a reentrant beat here, another couple of sinus beats, and then we're into tachycardia. Now, the pre-excitation does not show up overtly in this patient during adenosine, which is not uncommon. And the tachycardia resumes. And what we often hear about this is that the adenosine had no effect. Of course, the adenosine did have an effect, but it was very transient. Adenosine only has a very short half-life. This patient needs some form of chronic medication. And I'll mention beta blockers here. Beta blockers are used commonly. However, I avoid them in older patients with Wolff-Parkinson-White because, again, the risk of atrial fibrillation. Propranolol may increase the conduction through the accessory pathway. Now, people often think of this like a traffic jam situation where if you can't get through one route, the other route may go faster. It's not technically like that. It's more about refractory periods. If the conduction through the AV node is slowed, the propranolol may increasingly penetrate the accessory pathway, or rather decreasingly penetrate the accessory pathway and enhance conduction. A brief mention of some cures in our last few minutes. I mentioned Duke as an important institution in the early understandings of pre-excitation, and the first surgical division occurred at Duke in 1968. The first catheter ablation using DC energy occurred in the early 80s, and the first successful radiofrequency ablation was in 1987. And I checked in with a lot of our pediatric electrophysiologists who were both in training and who were working at that time, and the stories they were telling about particularly the DC ablations were quite something. So it took real pioneers to get to where we are today. And so today now, of course, it has become fairly standard to do an ablation. And I'll show you, it's one of the more gratifying procedures. You can see here, this is from an electrophysiology study.
Okay, let's take some questions, then replay the last part of the lecture. Dr. Najib, do you have any questions?
Yes, of course. Thank you very much. So far, it's an excellent presentation, second one as well as the first one. Dr. Sanatani, I do have this question from practical standpoint. Sometimes physicians will see patients who have exercise-triggered reentry SV tachycardia, and the question is whether or not this is considered more severe, worse outcomes, any risk of sudden death, or not, and how to deal with that, when to refer to electrophysiologist and when to treat medically and so forth.
Yeah, thank you, Najib. It is quite common to have exercise as a trigger for episodes of supraventricular tachycardia, and I must declare that, of course, I carry biases as an electrophysiologist and as someone who offers catheter ablation. My general principle is if this problem is interfering with quality of life, if this problem is interfering with fitness, so we see some children, they stop wanting to do activities, they quit the soccer team, those kind of things, then it's much better to get rid of the problem. Now, some people may not be ready for ablation. Medication is a very reasonable option that existed, of course, a long time. But we have a low threshold for doing an ablation in someone who is very symptomatic, even without exercise. So there aren't any studies that have identified exercise as a risk for more likelihood of AFib or cardiac events. And so we would not say that you are necessarily at higher risk of a cardiac arrest because your episodes are exercise triggered.
Oh, interesting. Then what is the risk? Two questions in terms of seeing a delta wave in a child without symptoms or any declared symptoms, and the other side of the question is those who have symptoms in a childhood age, what are the chances of self-resolving and not having any future arrhythmia for that matter? So is there any sort of remodeling or regression of these accessory pathways like in a healthy fashion?
Yeah, so great comments. The asymptomatic pre-excitation is a subject of some debate, and each year at various conferences we revisit this topic. And again, it's not an even playing field, because most of the people that express the opinions are people who also do ablation and enjoy ablation and see the rare cases of cardiac arrest from an asymptomatic WPW. But the risk is almost even whether you live your life with this asymptomatic pre-excitation or you undergo an ablation. Now, the exception, of course, if your accessory pathway is in a higher risk region, right at the AV node, or if you have multiple pathways or Epstein anomaly, those things move you more to a higher risk situation. But in general, ablation being quite a safe procedure now, and asymptomatic WPW especially with low risk pathway conduction. So you get on the treadmill and the pathway disappears, or it's intermittent, as I showed. Those are fairly low risk situations, and we cite risk of in the general group of asymptomatic WPW. We say about 1 in 1,000 risk, but it's very much a family perspective. So some families would rather not have the risk, and others think that's quite tolerable. Now, in terms of your other question, we've not done a great job of natural history of pre-excitation in the current era. We've modified the natural history, of course. The best chance you have of losing your pre-excitation is in infancy. So, of course, there's rapid changes in your first year of life. The heart evolves, you grow. If you still have pre-excitation beyond the first years of life, it may well persist. It won't necessarily be symptomatic, though. Now, if you present, though, as young as 4, 5, 6 years of age, then you are most likely to continue to have it. There's only about a 10 to 15% chance that you will outgrow the arrhythmia if you present even at school age. So by the time you're in your adolescent growth phase, it's likely to stay with you, symptomatic or asymptomatic.
Very nice, Dr. Najib and Dr. Sho. If you agree with me, there is a couple minutes left in the presentation, so we can just listen to the procedures and ablations and other interventions, and come back to the QA session. How's that?
Yeah, thank you. I apologize for the glitch in the video.
No worries, thank you.
Effectively block the accessory pathway. And we generally think that if it only takes a second or two, that's a better sign, although one can have recurrence. And again, ablation is something that we do quite commonly. There are, of course, still some unanswered questions I wonder about. I don't fully comprehend intermittent pre-excitation. Now, if a patient presents with supraventricular tachycardia, how hard should we look for the pre-excitation? Do they all need Holter monitors? Typically, adenosine may show a beat that may look like pre-excitation. In general, we don't have an extensive search for intermittent pre-excitation, but it's something to keep in mind. As someone who prescribes digoxin, particularly in neonates who may be geographically far from our center when they first present, I like to use digoxin, but certainly there are lots of centers that will not use digoxin. And then we still don't fully understand who is going to develop atrial fibrillation and how best we assess the high-risk properties of the accessory pathways. So that's our overview of Wolff-Parkinson-White, and I look forward to more conversations about this fascinating condition in the future. Now, hopefully by providing you with some information, we have changed the wolf in sheep's clothing to a sheep in wolf's clothing, meaning a less dangerous condition that you now understand better. So thank you very much.
Very good finish. Thank you so much, Professor Sho, for this fantastic presentation. Let's go back to Dr. Najib and Dr. Omar and see if we have any question left to help attendees to answer.
Yeah, of course, unless Dr. Omar has a question to introduce, I do have a couple. Dr. Gunaid, anything in mind?
Go ahead, Doctor.
Very well. So let me ask Dr. Sanatani, digoxin is back in the picture in congenital heart disease, like in single ventricle physiology, as well as in the adults with heart failure. And also, if we consider that some nations may not have access to all those medications, including sometimes beta blockers for the matter of cost and so forth and so forth, is there a way to stratify risks for Wolff-Parkinson patients in terms of, life-threatening events on the digoxin or not?
Well, you and I both likely are trying to formulate the research question that would answer this well. And the challenge, of course, in these in these studies is small numbers, and so even for some of our Wolff Parkinson White understanding who had life-threatening events, I think we had maybe 30 centers or more to pull together our cases. So we're going to be limited by small numbers. Most of the digoxin studies have been in lab models and not necessarily actual in living people where we've done pre and post accessory pathway refractory periods. I think we would find that there are so many variables, the condition of anesthetic, isoproterenol, things like that, that we don't have a meaningful endpoint. And again, the back to the bias, if you have someone who has to have catheters in the heart to really get the answer, they're going to say, why don't I just ablate the thing while I'm here? So we're a bit limited. I think, the fact that we have probably, hundreds of uses of digoxin in places where we, as you say, we may not know the child has Wolff Parkinson White, they may not have other options. I think, a bit like stimulant medication, there's not really a signal there in the population. So I feel quite safe with digoxin, even in older kids with WPW.
Oh, very well. Dr. Nueja has a question, and then there's a question addressed to her. So let me ask her the question, Dr. Hadir. Her question is to you, Dr. Sanatani. What are the most common adverse outcomes after catheter ablation for WPW, especially recurrence rates and conduction disturbances in the AV node for that matter?
So this is for Dr. Sanatani.
Yeah, thank you. So in general, ablation now has become quite a safe procedure. The risk of damage to the AV node with the advent of cryoablation is, it's not zero, but it's negligible, because if we find that we're working right near the AV node, we can switch to cryo, and then we can freeze, which of course is reversible as compared to radiofrequency. So typically our biggest complication is that they can have recurrence of the accessory pathway, possibly symptoms, which depending on the location of the pathway, right-sided pathways are slightly higher risk. 10 to 15% recurrence is about as high as the numbers get in publications and presentations, but somewhere between we say 1 in 10 can have a recurrence. Minor complications, some leg pain, some chest pain, very common, those go away. Have we seen more malignant complications such as coronary stenosis that were described early? We have not seen that clinically. We have not looked for it aggressively. We think that as a community, we have learned quite a bit about catheter ablation, and so we would say that the risks are less than 1%, and the success rates for most WPW will be higher than 95%.
Very nice, very nice. Dr. Nueja, the question for you now from Dr. Nawal Belarusi. She's asking about your presentation. Why did the child did not undergo electrophysiology study for his post-cardiac arrest? And for the posterior wall trabeculation, should you complete the investigation with cardiac MRI to rule out LV non-compaction?
Yeah, thank you for the question. Regarding the first part of the question, given that the patient's stable hemodynamic status, catheter ablation was initially deferred, and additional antiarrhythmic treatment, as we see, was attempted. So, following the lack of response to sotalol, flecainide, and high-dose propranolol, the preparations for the ablation were initiated, considering previous report describing the use of ivabradine and CPVT-related ventricular arrhythmias and its efficacy in ectopic atrial tachycardia. Ivabradine therapy was initiated, and it was effective. Regarding the second part of the question, I can't give you a definite answer, but I think they found that trabeculation was not significant to proceed at the moment to proceed for MRI.
Very well. There is a very interesting question now for both of you, a very practical question. Is there any other investigation to detect arrhythmias in patients with normal EKG, Holter, and echo? But more important in this question from Dr. Rania Osama, knowing patients suffering from repeated attacks of tachycardia with chest pain. So we have tachycardia and chest pain. Besides electrophysiology, look at these cases. What is your basic element in the questionnaire going over with the patient to tease out whether or not the patient has potential arrhythmia, tachyarrhythmia or not, and whether the chest pain is related to that?
I'm happy to speak to this. It's a very common constellation of symptoms that we see. We see especially a lot of adolescents where we see chest pain and palpitations. And I'm quite old-fashioned, and I spend quite a bit of time taking the history. And for example, a teenager who has palpitations every day that are 30 seconds, 1 minute, that is almost never an arrhythmia. The gratifying thing is with very frequent symptoms, you can usually get some symptoms on a Holter monitor or some short-term strategy. The more typical palpitations that are going to be an arrhythmia, they tend to be, the family will often say cluster or random, and the episodes are, 5 to 10 minutes. They're a bit longer and they're infrequent. Now, of course, we have technologies. We have used the Cardia monitor, which is just one example of this sort of, where you place your fingers on it and can record a fairly good quality rhythm strip. We have people, of course, coming in now with their smartwatches and their smartphones with all kinds of information. So I think it's actually contributing to a faster track from symptom to diagnosis and to treatment. And I think the technology in general has been good in terms. I don't think there is that many false positives, let's say. Now the chest pain, again, it's all in context. The adolescent who has a lot of other things going on, maybe some orthostatic dizziness, fatigue, frequent palpitations. I find chest pain is often bundled with that. The children who have supraventricular tachycardia, they will often describe a discomfort. They don't necessarily say it's painful. They say it is uncomfortable. And so again, I spend a lot of time really taking the history from these patients. And you can hear my beeper going in the background, so I'll mute myself. And it's been wonderful to speak to everyone again.
Thank you, Sanatani. That everyone is grateful for your talk and the Q&A period. Have a good luck with your on-call today. Dr. Nweja, do you have anything else to add to the last question? And potentially, the final question would be addressed to you. For fetal SVTAC, what would be the best recommendation in terms of safety, not simply in terms of response between amiodarone and beta blockers?
I think Dear might have internet issue. She is muted. Do you have any further question, Dr. Najib, to give Ghadir a chance to connect?
Is Dr. Sanatani still with us?
He has to answer his pager, so he's busy in the hospital right now.
So both of them, they are busy, so we are waiting for them.
Do you have any further questions, the QA box?
Yeah, there are some questions. One question I could probably, do we have Dr. Nweja with us? There is one question about epilepsy and Wolff Parkinson White. I might try to answer this question from a clinical practitioner addressing these problems in and out. I don't think there's any direct link between the two, although both are related to electric impulse, one in the brain, one in the heart. But apparently, at least genetically speaking, there's nothing known between the two. And I wonder how this question came about. But certainly, Wolff-Parkinson-White could lead in rare instances to sudden death or aborted sudden death. Whether or not this is going to cause in low cardiac output with severe outcomes, Wolff-Parkinson-White would lead to epileptic activity or actually a convulsion, not to mention epilepsy as a disease. It is a possible thing. Another thing in athletes, high-level athletes like marathon runners, there are cases of Wolff-Parkinson-White leading to sudden death or leading to aborted sudden death. Again, athletes should be warned about their condition if they have it, and potentially, as I know, many high-level athletes would go for ablation just simply to avoid these complications in the future, life-threatening complications.
So you
Very
answer a
nice.
couple of questions, mashallah.
Very good, very good. So I think this has been very thoughtful and informative. We all have learned it today. And hopefully by tomorrow, everyone should get the YouTube link of the recorded webinar. Again, by next week, all attendees should get the certificate of attendance. Next month, we will have another pediatric cardiology and pediatric critical care webinars. So please stay tuned. We are going to share the information of both webinars shortly. If you haven't joined the WICCM YouTube channel or social media platform, please go ahead and do. We already shared the link in the chat box. So please join our community. We are doing free education about once or twice every week. And also we are running several high quality, well-structured educational programs if you are interested to join. With that, I wish good rest of your day, your afternoon, your evening, your night, wherever you are. Thank you.
Thank you.
Thank you, everyone.
Bye.